What is TAVI?
Patients who are suffering from aortic stenosis, there is no medicine which can treat this disease. TAVI is a preferred treatment for such patients.
How does TAVI differ from traditional open heart surgeries?
We have to choose the right therapy for the right patient at the right time. The TAVI valve is going to last as long as the surgical valve. In young patients, still it is surgery, and in patients above age of 65 years, TAVI is preferred.
So what makes it true game changer?
The recovery is so fast, these patients stay in ICU for just one day. Third day, they are ready to go back home.
Anesthesia plays a very crucial role.
We think 2 to 3 steps ahead by close monitoring the patient and keeping the emergency drugs ready quickly. Patient's outcome was safe because of that.
Patients who are at high risk, what reassurance would you like to give?
We would educate them about the complication. To treat the complications, we have a bailout strategy, we have a plan B, plan C in place.
Hello, this is Neha and welcome to Lilavati Hospital's official podcast series where we bring you one step closer to the expertise, innovations and patient care that define our institution. In today's episode, we explore the evolvement of structural heart disease including TAVI and TMVR. Joining with us, we have Dr. Ravinder Singh, interventional cardiologist specialized in TAVI and TMVR, and Dr. Namrata Kothari, who is a cardiac anesthesiologist. We welcome both of you here.
Thank you.
To begin with, for our listeners, sir, we would like to know what is TAVI and who is it recommended for?
So TAVI stands for transcatheter aortic valve implantation. Means we are replacing the aortic valve with a catheter-based procedure. So in this procedure, what we do is patients suffering from aortic stenosis. We replace the aortic valve by putting a catheter into the groin vessel. We go inside the heart, put the new valve inside the old valve, and it starts functioning immediately. Now, who requires TAVI procedure? Patients who are suffering from aortic stenosis, which refers to a disease in which the main valve of the heart, called as aortic valve, narrows. And because the valve is narrowed, the heart has to pump with greater force. There is no medicine which can treat this disease. Only way to treat this disease is to replace the valve. Traditionally, the valve was replaced by open heart surgery. Now we can replace it with a catheter-based procedure. Now, to generalize it, patients above age of 65 years, and if they are suffering from aortic stenosis, and if we can replace the valve through the groin vessel, TAVI is a preferred treatment for such patients.
So how does TAVI differ from the traditional open heart surgeries? Like, what is the outcome for the patient's recovery and their experience?
That's a very important question because all patients who come to see us, one common thing between both the procedures is both type of patients are suffering from aortic stenosis, and another similarity is in both the patients we have to replace the valve. Now in a surgical, we would open the chest, put the new valve by open heart surgery. How do we do in TAVI? There is no open heart surgery involved. There is not a single scar incision on the chest. We go from the groin vessel and put the new valve inside the old valve. Now, both the treatments are relevant for a certain type of patients. Let's say we see a young patient below the age of 65 years. We would recommend surgery for them until unless somebody cannot undergo a surgery. Like we did a 27-year-old pregnant lady, we did a 40-year-old 140-kilogram patient. So if patient is not fit for surgery and patient is below the age of 65 years, we might offer TAVI for those patients. Otherwise, all patients above age of 65 years, and if we can replace the valve with a TAVI procedure, TAVI is preferred. In young patients, still it is surgery, and in patients above age of 65 years, TAVI is preferred. Now, this is the broad difference between these two type of therapies. But sometimes, we have to choose the right therapy for the right patient at the right time. Overall, the long-term result, let's say there is no difference. We have data up till 10 years. The TAVI valve is going to last as long as the surgical valve. There are certain differences in the short-term outcome, but I would always tell the patient, go and see your cardiologist and they will help you to understand which therapy is better for you.
So structural interventions like you mentioned, like TAVI and TMVR. So what makes it like a true game changer as compared to the conventional open heart surgeries?
Number one, if the TAVI or the TMVR is done in the right manner in the right patients, there is very fast recovery. These patients, we replace the valve, there is no general anesthesia involved, there is no ventilator involved. These patients stay in ICU for just one day. Very next day, we shift them to the room. In the room, in the corridor, we would make them walk. these patients would start walking very next day. Day 2, day 3, third day, they are ready to go back home. Now, once they are back home, they resume their daily activities very fast. And after 7 days, we would see some of these patients going back to their offices. The recovery is so fast, especially in mitral valve side also. We have had patients who have told us, doctor, I've slept for the first time in 6 months without any breathlessness. So speedy recovery, provided the TAVR and TMVR is done in the right manner. We have, there is an evidence and paper which was published in NEGM, which stands for New England Journal of Medicine, which is like a Bible of or a holy book for medical doctors, which showed that the outcome of TAVI depends on the operator experience as well as the center volume. More the experience, better the outcome and lesser the complications.
So Lilavati Hospital has encountered many TAVI cases. So what are the key factors in managing those cases?
The outcome of a TAVI procedure, we have developed so much of experience that we are able to offer safe outcomes even in complex scenario. Here, the outcomes of all our TAVI patients are at par with any center in the world. The pacemaker rate is less than 5%. The mortality, the chances of losing a patient is 0.01%. The chances of stroke is less than 1%, which is 0.9%. The average hospital stay is just 3 to 5 days. We have had patients traveling from all across the country, patients coming from down south. We had patients coming out of country as well, where they have trusted the outcome of the entire team the way we would do the aortic valve procedures.
In one of the recent cases, sir, there was a significant risk in coronary occlusion, which was due to low coronary height. So, in handling those cases, what was going through your mind that to stabilize that patient in such a condition?
This was a very interesting case. The patient lives in Pune. The patient's son is a urologist in US. Another son was a head of ICU department in Pune. Now, patient was evaluated for TAVI procedure. Patient was deemed high risk for TAVI procedure. Patient came to us. Now, in these type of patients, we would do TAVI with coronary protection. We make sure that the coronary artery is not occluded, the blood supply to the coronary keeps flowing, and by this we can prevent heart attacks. There are two ways we do this. One is we protect the coronary artery with something called a stent. In a common man's term, it is like a chimney protection. And the second is what we do is we split the leaflet with an electrowired surgery, which is called basilica. By doing this, we create a hole or a split in the artery, and blood keeps flowing through this split into the coronary artery. So the chances of coronary occlusion and heart attack during a TAVR procedure are minimized.
And in another case, there was a TMVR with vegetation, which was at a risk of embolism or at a higher risk. So what were the precautions that were taken by you to ensure the safe outcome of that patient?
So this patient had a bad mitral valve. The patient underwent a mitral valve surgery almost 10 to 12 years ago. The mitral valve had started leaking, and there was something which was mobile moving on the mitral valve leaflet. We made sure there was no acute infection or active infection by doing certain blood tests. Now, one of the problems which can happen when we do these mitral valve replacement is these small things can break and go to the brain. How do you protect the brain? In the past, we would deploy a filter, but that filter is no longer available. So what we did is we went from the femoral artery, groin vessel, went into both the blood vessels which supply the brain, and we put two special filters in both the blood vessels. And then we went ahead and did the valve replacement. The idea was if any small particle which is there on the leaflet, it breaks, it will be captured by these filters. So the blood will keep going to the brain, but any small particle will be captured and we would remove it. We did a successful TMVR with cerebral protection in this patient. The new valve was inserted, it started functioning immediately, and today, even after just second day, this patient started walking. There was improvement in breathing. The filters which we deployed in the brain vessel captured some debris, and then we removed it out of the body. So this filters proved that it was beneficial in protecting the brain, and the small particle was captured by the filters and removed from the body.
As anesthesia plays a very crucial role in all the surgical procedures. So, ma'am, how does cardiology and anesthesia go exactly in sync to maintain or to bring a very good outcome of a patient?
Synchronization begins well in advance before the patient is taken on the cath lab table.
Yeah.
Okay. As a team, we sit together, we review the CT findings, and we plan the procedure beforehand. We also discuss how we will approach this procedure, and if we are anticipating any complications, how we are going to treat that complication on table. So we are prepared beforehand, before we take the patient on table, that how we are going to go through these procedures. During the procedure, communication is constant. From anesthesia side, I'm continuously monitoring the blood pressure and rhythm and stabilizing the patient all throughout the procedure while valve is being deployed, so which is very important critical event during the procedure. So having said that, as an anesthesiologist, we think 2 to 3 steps ahead and keep preparing ourselves for unexpected. While we are doing the procedure, self and Dr. Ravinder is on the same page. So we are able to manage patients smoothly during the procedure, even in a high-risk situations. This is how.
So, Kothari ma'am, as you are a cardiac anesthesiologist, your role is often very critical, but yet unnoticed by many of us. So, how does anesthesia directly influence the outcome of a cardiac surgery?
Here we are discussing that in the difficult situations, how anesthesiologists actively or proactively
Yes.
work to change the outcome of the patient.
Yes.
Okay, so we recently done one high-risk case in which sir already discussed that there was a possibility of coronary occlusion.
Yeah.
Okay, so this was a patient where the anatomy was such that annulus was small and coronary was at the low level. So while placing the valve, there was a possibility of coronary blockage. As an anesthesiologist, we anticipate these events that patient can have coronary blockage, and during that situation, patient may have a low blood pressure or arrhythmias or even a cardiac arrest. So as an anesthesiologist, I was prepared to deal with this situation beforehand by close monitoring the patient and keeping the emergency drugs ready and attaching the defibrillator to the patient beforehand and keeping the blood available inside the operation theatre. So having said that, by close monitoring and due to availability of all the stuff inside the theatre, it was easy to manage that emergency situation quickly, and we could respond better to the situation, and patient's outcome was safe because of that.
And ma'am, how is this cardiac anesthesia, the structural procedures that you undergo, the anesthesia that you give in this procedure, different from the other?
So in these cases, we are using conscious sedation, which means that we are giving a patient a continuous infusion of the sedation along with the painkillers so that the patient remains stable on the table without moving, and we are able to perform the procedure without any discomfort. Since we are using minimal amount of the drugs all throughout the procedure, patient recover fast immediately after the procedure and ICU stay is minimized.
For the patients, sir, who are at a high risk, there are obvious chances for them to be anxious. For such patients, what reassurance would you like to give?
I mean, that's again a very important question. See, all these procedures, when we do, they carry a certain risk. Then why do we do the procedure? We do the procedure when the risk in the disease is more than the risk in the procedure. Now, the way to reassure is actually to educate the patient. We would educate them, what are the types of complications, what things can go wrong, and still, why are we doing the treatment? Then we have to also educate them the risk involved in not treating the patient.
Yes.
Number one. Number two, we would also educate them about the plans. How are we going to tackle those complications? What is the plan A, B, C, which we have in place to take care of such patients? So, complications, are part of the procedure. We would always say that. But as we all gain experience, as we do more and more procedures, we would anticipate certain things and we can minimize the complications. To treat the complications, we have a bailout strategy, we have a plan B, plan C in place. Now, your question was very specific. How do we remove the anxiousness, anxiety of the patient,
Yes.
the patient relative? That is just by sheer education. We would educate them about the disease, we would educate them about the treatments, we would educate them about the complications, we would also educate them about how will we treat the complication. And then we're going to share what is our own complication rate of a certain procedure in a certain set, which is now at the lowest because of the whole experience which we have gained.
Yes, sir, definitely it would help the patients for their better recovery and will reduce the anxiousness of the patients. Now, looking ahead, these structural interventions like TAVI and TMVR. So, where do you see yourself in the next 5 to 10 years from now?
The transcatheter valve procedures, the transcatheter valve replacements, transcatheter valve repairs, and also transcatheter coronary procedures, angioplasties, they are growing. And we have generated a lot of evidence where we see that the TAVI or TMVR, the results are equivalent or maybe better in certain subset of patients compared to an open heart surgery. So your question is, how do we see ourselves in next 10 to 15 years? We would like to grow our whole team as well as our approach, and also so that more and more patients who are suffering from these valvular heart disease can benefit from the therapy and also from our whole experience. So, but the most important thing is, we have to offer the right therapy to the right patient at the right time. That does not mean that the TAVR and TMVR are going to replace the open heart surgery. We just have to identify the right patient, educate them, and offer the right therapy at the right time. In next 10 to 15 years, as our country is growing, we would see more and more patients benefiting from transcatheter valve replacements and repair.
As more and more patients will definitely benefit from the TAVI and TMVR procedures, our viewers would also have benefited from the session, which was very insightful. And here now we have come to an end of this session. Now I'm very thankful for ma'am and sir to be here. It was very good knowing about the cardiac issues and the structural interventions which Lilavati Hospital is going ahead with. Thank you so much, ma'am. Thank you so much, sir.
Thank you.